Yep, perfect.
So I'm going to give a brief talk about, some treatment options for migraine. I know that you guys have heard some really fabulous talks about non-medication related strategies and therapies, which I think are really exciting to think about. And most of this talk is going to focus on medications. But of course, medications don't supplant all of the other wonderful things that you guys have heard about or learned about today. I have no relevant disclosures for this talk. I'm going to go over a basic approach to treatment and what we think about as headache medicine specialists. I'm going to go over some of the abortive and preventive treatments, and then I'll briefly talk about some things that may be in the pipeline. So I don't have to tell you guys about how burdensome migraine and headache disorders are, but it is very interesting to note that it is really one of the leading causes of years lost due to disability worldwide. So you guys are not alone in migraine, and in fact, there should be more attention paid to migraine given the fact that headache is such an extraordinarily disabling and common condition, with chronic migraine representing a lower proportion of the world's global disability, but still contributing to a lot of disability in patients. And chronic headache is really defined as having 15 or more headache days per month. Most of headache treatment really centers around the patient, around the individual patient. Sometimes we think about the context of what other medical conditions a patient may have, what their daily activities might be, but really the goal is that we meet the expectation of the patient to be headache or pain-free and to experience less disability and impact in terms of their headache on their daily living or daily lives. So these are some general goals that I think are really important when we think about migraine treatments. We want to be able to alleviate suffering. We want the headache relief to be rapid. We want to restore function. We want to limit disability. We want to optimize the ability of patients to be able to care for themselves and have that empowerment. And of course, we want to do so while producing the least amount of side effects possible. In terms of asking patients about what they might think is a good strategy for headache treatment, patients do report that what they want is pain relief that does not take too long, pain relief that works and works consistently, and pain relief that has very few side effects. And so that's really the focus of treatment. There are two general principles that we think about when we think about migraine treatment. The first is abortive or acute treatment. And these medications should really be thought of like painkillers. So these are the medications that you take as needed to reduce the headache attack severity or intensity, or to abort the headache attack when you have it. So think of these as your painkillers. These should not be overused, and they should only be taken as needed. The second category of medications are preventive medications. And these medications are ones that patients take on a daily basis. These are not really thought of in the traditional sense as painkillers. What they're meant to do is to reduce the frequency of headache attacks so that you have fewer days per month where you're suffering with a headache. These medications do take time to become effective, so there does have to be some patience when taking or starting a new preventive medication. But the purpose is to reduce the headache frequency, to reduce the disability and severity. We tend to think about starting preventive medications when the headache attack frequency reaches about 4 to 6 headache days per month. That's when we start to have the discussion with our patients. It's not, an all or none phenomenon. It really is a discussion and a partnership with your headache doctor. If the headaches are very severe and very disabling, we may think about starting a preventive medication, even if the headaches are not very frequent. So general principles when treating migraine attacks, we tend to recommend treating the attacks early, so not waiting too long before taking an abortive medication, to choose the treatment based on the severity of the disease. Acute treatments can be combined. So you can take, for example, a triptan medication like Imitrex or sumatriptan with an anti-nausea medication like Zofran. You can take those together. And then preventive strategies, including non-medication and medication-related strategies, depending on the attack frequency and the attack severity. So what are we actually targeting when we treat migraine? This is a question that I get from my patients a lot. You know, what is this preventive medication actually doing? And I think that it's a really great and insightful question. Some of the medications that we use targets brain excitability. And some of the medications that we use target specific neurotransmitters in the brain, like serotonin and norepinephrine systems that we think are involved in pain. Others actually target pain sensing nerve fibers, so pain nerves that can become activated with headache. Others target inflammation, and the most recent medications actually target pain signaling proteins, one of which is calcitonin gene-related protein, or CGRP, which is a pain sensing protein that's released from nerve terminals that can signal or produce pain in the head and neck. So in terms of acute migraine treatments, they can fall into two categories. One is less specific, the other is more specific. For the less specific categories, we think about things like nonsteroidal anti-inflammatory drugs. These are medications like ibuprofen or Motrin, Excedrin. Many of them are over the counter, but we call them less specific because they can be used for other pain conditions like arthritis, for example. Anti-nausea medications can be really helpful to reduce nausea and vomiting during headache attacks. Sometimes antihistamines can also be helpful, both in the reduction of nausea and vomiting and to reduce some of the side effect profiles of the anti-nausea medications. Some of the more specific medications I'll spend a little bit of time on. They include medications like triptans, ditans, and gepants. And of these three, the ditans and the gepants are the newer versions of medications. And I'll talk a little bit more about that. So I have a couple of slides on those. So your NSAIDs, your nonsteroidal anti-inflammatory medications are tried and true. A lot of headache patients, by the time they come to see a headache medicine specialist, have tried these over-the-counter medicines. Again, Advil, Motrin, ibuprofen, those types of medications. Some of them are prescription strength. The important thing about taking these medications is some people talk about things like medication overuse headache. What's even more important than that is that if you take too much of these medications, they can also lead to other issues, not just medication overuse, but also stomach irritation, kidney dysfunction. So it's important to use these medications only as needed and not to overuse these medications. Triptans are really the core of migraine treatment. They're more specific than the NSAIDs. There have been several clinical trials that demonstrate that they are effective, although they're not effective for everybody. In a small percentage of people, they can worsen the headache, but in most people, they can abort the headache within 2 hours. Some people will have to redose their triptans. So when they take it at the beginning of their migraine, they may need to take a subsequent medication. There are differences in how fast they act and how long they act. You may notice that there are a number of different triptans out there on the market. They just have slightly different profiles. So some of them act more rapidly than others. And there are also differences in formulation as well. So this particular table just sort of compares the different triptans. I mean, you guys are maybe very familiar with the different forms, but there's Emerge, there's Imitrex, there are all sorts of medications, Relpax, rizatriptan. A lot of the difference between them is how rapidly they act. So their onset time and how long they're effective. And so what we tend to do is in patients that have headaches that are really severe, and if you give them a triptan, it can abort the headache right away, but they need that rapid onset of relief, then we tend to give the medication that has a more rapid onset. For people that say, I always have to take a second dose, and sometimes even then the headache comes back, then we may give a longer acting triptan like naratriptan or frovatriptan. It acts a little bit longer, but it takes a little bit longer to work as well. And so that's kind of how we think about the dosing of the medications. So in terms of pipeline and what's new, lasmenitan Rayvow is one of the newer medications for the treatment of migraine. This medication has been demonstrated in clinical trials to be effective for treating headaches. The reason why they wanted to generate this particular medication is so that it does not have some of the vascular potential side effects of the triptan medications. So in people that have vascular disease or where you're concerned about heart attacks or strokes or high cholesterol and high blood pressure, this medication is thought to be safer from a vascular standpoint. Some of the difficulty with this medication, it is more sedating than the triptans, and people had difficulty driving when they took this medication. Therefore, it is considered a controlled substance, but it has been effective in clinical trials for the abortive treatment of headache. So that's lasmenitan. There are these other two new medications that recently came out as well. These are new medications for the abortive treatment of headache. So remember I talked about that pain protein, CGRP? Well, these medications actually target the receptor of that protein. And so it blocks the ability of this pain protein from being able to signal to pain fibers. What's really unique about this medication, as well as lasmenitan, the one that I just talked about, is that these were really generated specifically for the treatment of migraine. These two medications are called Nurtec and Ubrelvy, and they can be used as abortive treatment, and there are clinical trials that suggest that both of them have good efficacy for the abortive treatments of headache. So gone are the days where we like to prescribe opioids and barbiturates for the abortive treatment of headache. And that's really because both opioids as well as barbiturates like Fioricet or Fiorinol can be addictive. They can lead to dependency, and they are associated with medication overuse. And so we only use these medications in extreme circumstances and as a last resort. We don't reach for them first because we know that in the long term, they can cause more difficulty in the treatment of headache. For some patients where we have, very limited medications, then we sometimes use them, but only in those select cases. And really we use them very, very sparingly. So what about preventive therapies? This is a slide that's too busy for you guys to read through, really, but what the slide attempts to talk about is how complex the discussion should be and is. When we think about preventive therapy, we have to think about what's the patient's goal? Like, what does the patient think about starting a preventive medication? What's most optimal for them and what's not? Some patients don't want to start a preventive medication, even if they have a high frequency of headache. We still need to be able to provide treatment strategies for those patients that are non-medication related. Maybe a supplement would work, maybe some other modality would work, maybe neuromodulation. And so this is a really complex discussion. And oftentimes this is discussion that, at least for my patients, I have over several sessions to try to get a sense of what goals they have for preventive medication and what would work best with their life and their lifestyle and what their expectations are. Oftentimes, preventive medications, these are the ones you take daily for the most part, are incremental in nature in that they don't tend to work right away. And sometimes we try one preventive medication and then it doesn't work and we have to try another one. And that can be really difficult because it kind of seems like, well, we're just grabbing things off the shelf and, shooting in the dark and hoping that things work. But really it's because we don't have clear biomarkers or indicators to know which patient is going to respond to which specific preventive medication. So we try to select ones that have really good efficacy, really good evidence, for their effectiveness that have lower side effect profiles. And we try those medications first to see whether or not patients will respond and to see what the side effect profile is in that particular patient. Not every patient has a side effect to medications. So even though we talk about side effects, not every patient will have that side effect. It's important to know that there are a host of things that complement prescription medications. And sometimes these things are more important than prescription medications. So diet and exercise and all of the things that you guys have already learned about or heard about are all very, very important strategies and can be used to complement medications, not just complement, in some cases, even supplant medications. So all of those strategies, mindfulness-based meditation and other strategies, are really important therapeutic strategies in our armamentarium for treating migraine. Some people will start with a nutritional supplement. These nutritional supplements are ones that do have clinical evidence for their efficacy. So magnesium, riboflavin, feverfew, coenzyme Q10, which I don't have on the slide, all have evidence that they can work to reduce headache attack frequency. We tend to avoid butterbur because it can cause liver dysfunction. If you're started on butterbur, it's important that your headache medicine specialist checks your liver to make sure that you're not developing any liver dysfunction as a result. So there are a host of medications that we have traditionally used for the treatment of migraine. You may have come across these. They include the tricyclic antidepressant medications that alter serotonin and norepinephrine neurotransmitters in the brain. They include anti-seizure medications like Topamax or topiramate that alters electrical excitability in the brain. There are other medications like beta blockers, metoprolol and propranolol that alter neuroadrenergic signaling in the brain. So you'll notice that most of these medications target neurotransmitters in the brain. And those neurotransmitters are likely involved in pain signaling. And that's how most of these prescription strength medications work that are used on a daily basis to reduce the frequency of headache. The general principles for these medications are that we typically start at a low dose and go slowly over time, that it takes time for them to work. It's helpful if you have a headache calendar so that you know what works and what doesn't. And it's also helpful if you keep a tally of the medications you've tried and what has worked and what hasn't and what side effect profile you've had. And that's only because if you switch from one headache specialist to another, you're the best person to know exactly what you've taken, what you've tried, what's helped and what hasn't been helpful. Botox is also one where there's evidence for the preventive treatment of migraine. It's given as a series of injections in the head and neck. That series of injections is given every 3 months. And this is specifically for patients that have chronic migraine, so greater than 15 headache days per month, 8 of which meet the criteria for migraine. Often patients would have had to fail other migraine preventive medications to qualify for this drug to be covered under their insurance. And so Botox can be helpful in reducing headache attack frequency in those with chronic migraine. Then there are the new antibody medications. Have you guys heard of some of these newer antibody medicines? These are once monthly injections. For the most part, remember I talked before about CGRP and how we have abortive medications to target CGRP. Well, now we have preventive antibodies that also target this pain sensing protein. And these antibodies come in a variety of forms and formulations, but they're typically once a month injections that you inject yourself for 3 out of the 4. And those injections are subcutaneous injections, and they're really used for the treatment of migraine to prevent migraine attacks. And so this is really a new medication out on the market. And we've had really good success with these medications in that patients have fewer side effects. associated with them, but people can have injection site reaction with amobig, which is one of them. You can have constipation. So there are side effects with these medications, but on par, there tend to be fewer side effects. So this is actually my last slide because I wanted there to be some time for questions and all of that. So one question is, what is in the pipeline? What things can we expect in the future in terms of medications? Let me first start by saying that I didn't focus much on any of the neuromodulators like Cephally device or some of those. Most of this is focused on medications, but there are neuromodulatory therapies coming down the pike. The National Institutes of Health, or NIH, has this huge program that's really a multi-billion-dollar effort to look at non-medication related strategies to help with pain conditions, and migraine is on their docket. And so they have funded a lot of clinical trials looking at neuromodulation and how you can use neuromodulation for the treatment of headache. And the purpose is really to spare people from taking things like opioids, which can be very addicting. So better neuromodulatory therapies are definitely down the pike. The CGRP blockers, the ones that are abortive, the ones that I mentioned, the Ubrelvy, for example, and the Rimegepant, those medications are mostly pill forms, but they're altering those medications so that there's more diversity in how you can take it. So there's a nasal spray, for example, that will probably be coming out fairly soon. And there's going to be other formulations of those what we call small molecule blockers. The other strategies are focused on other proteins, other pain sensing proteins. And so we've had some success with CGRP and targeting CGRP, which is why we have the antibodies and we have the small molecule blockers. And so people have wondered, are there other proteins that we can target? And so PACAP and other proteins have come up as potential targets. And so those are the ones that are now also down the pike in terms of medications that we want to try over time. And so those are the ones that'll probably come out soon. So this is actually my last slide. Do you know how much time that we have for questions?
We have, I would welcome any questions. We probably have a good 5 or 6 minutes.
Okay.
So those of you in the audience that have questions, there was a lot of valuable information there. One question, we reached out to see if some of our registrants had questions, and one, you mentioned the neuromodulation devices, and you're excited about a large funding for an upcoming study. What kind of time frame would you think, not that you could guess, but do you see on that horizon?
Yeah, so oftentimes it does take time to get a neuromodulatory system up and running, right? Because there has to be clinical trials that demonstrate its safety, and then there has to be clinical trials that demonstrate efficacy. They don't go through all of the same process through the Food and Drug Administration as other medications do. What I will say is that if the neuromodulation tends to be fairly safe, then oftentimes they can make it out on the market sooner than even the medications. So I think that that's helpful. Some of the other things that are sort of new that you probably should know about is some devices may be available now, like the Cephally device, for example, may be available over the counter soon. And so there are making some changes to neuromodulation devices so that they could be more accessible to patients, and hopefully we'll have more options available. The other thing is some of the neuromodulations that are used in the general pain setting may be tested for migraine. And so that'll be very interesting because these are neuromodulatory devices that have already been approved for other indications. And so revamping those devices to see if they can modulate headache may mean that they get out to market a little bit sooner.
Okay, great, thanks. We had a question come in. What, if anything, do you know about the effect of COVID infection on migraine outcomes?
That's an excellent question. So there have been several questions about ACE inhibitors, which are migraine preventive medications, and whether or not people that have migraine and are on an ACE inhibitor are more likely to develop COVID-19 or COVID-related infection. I don't think that there is good evidence to suggest that there is any correlation between having migraine or being on an ACE inhibitor for the prevention of migraine and the development of COVID or COVID-19 symptoms. What I will say, however, is headache apparently is a symptom that has come up in COVID-19 infection. And so in people that have a pre-existing history of headache disorders, that headache may be worse or they may experience a new headache. Just like with any other infection, when migraineurs develop infection, they can get worsening of their baseline migraine headache severity and frequency. So it may interact in that way. The other thing is that we've learned is that some of the medications that are used in clinical trials, like inhaled nitric oxide, can precipitate massive headaches in people. And we know that nitric oxide can actually precipitate migraines in people that have a history of migraine. And so there is some interaction there, but it doesn't appear that migraineurs are at a dramatically increased risk of developing COVID-19 infection, or that they have worse outcomes, for example, than non-migraine patients. And it doesn't appear that that's really related to being on an ACE inhibitor or an ARB, which has been some of the discussion that I've seen among patients.
Great, that was a good question. Good question, good information there. Another question comes in asking, can amobig lose effectiveness over time?
That's an excellent question. And it's not just related to amobig, it's also related to other preventive medications. Many patients will report when they start a preventive medication, it seems like it's effective. And then they wait a little bit longer and their headaches again start to get out of control or get more frequent. And so it seems that when they start a medication, it's effective initially, but then it loses effectiveness over time. So I don't really think that that phenomenon is unique to amobig. We do see patients describing that with other medications as well. Oftentimes, the first thing I explore is what might have changed. Because for many patients, there are external factors, maybe not, I don't necessarily call them triggers, I just call them environmental external factors that may lead to an increased frequency of attacks. And it may not be that the medication is losing effectiveness. It may be that there are other things that are happening in the background that it's making the medication less effective, but it can still work if those things are targeted. So I don't think that amobig is unique in that potential experience.
Thank you. Do you recommend, or what's your position on whether it be a migraine journal that includes tracking nutrition, or I guess I should ask you, do you encourage a migraine journal? And what do you suggest be included that would assist in the relationship with someone's neurologist or headache specialist?
Yes, that's a great question. So everyone is slightly different. So I don't want to discourage anyone from doing something. And for some people, for example, keeping a food log or a nutrition journal is more than just about their migraine. It can be about their wellness and their, generally just taking account of what they're eating and what they're doing during the course of the day. And so it can help with your overall fitness. That being said, I think that some food diaries can be very laborious for patients to track, what did I eat today? How much of it did I eat? Oftentimes, patients that have true food-related triggers know it. That's what I find in my patient population. If every time you eat drink tomato soup, you get a migraine, most patients actually know it, and they don't have to keep a food log to discover that. But what I do find is interesting to do is to keep a headache calendar or diary, especially when you're altering or changing medications, because sometimes thinking back on whether or not some medication changed your headache, it's really difficult to remember like what exactly was my frequency before, especially if the change is occurring slowly over time or incrementally. So I think that in that case, keeping a headache calendar of how many headache days you have per month or the severity can be really helpful to actually visually see that your headaches may be improving or not improving with a specific medication.
Okay, great. That seems like good advice. Are there apps for that? Not having migraine.
There are apps. There are things that you can do online as well. So there are apps that are available on the phone, on your phone. There are websites Migraine Trust has one, for example. There's Migraine Buddy. There are a host of apps that help you keep track of your headaches, and that can provide greater information. And some of the apps even allow you to make printouts and things like that. So they can actually be really helpful.
I don't know if this is a question, but I hear it asked in other sessions, and I don't know if the virtual environment is assisting in this or not, or the social media world, but I'm finding that so many of our specialists, headache specialists that we have on board, really approach it like you do, to treat every patient individually as different, that never stop looking at options, offering options because there are many, staying hopeful, and really being a serious partner, life partner with your patients. But what if a person doesn't have that? Are there other ways to get that support, or what's your suggestion?
So I would say that one of the biggest support mechanisms is having groups like this, right? It's really invaluable to have groups like this. I honestly think that Zoom is actually becoming extremely helpful for patients, because they, at least for me anyway, I'm seeing a new patient population that's connecting with me that are not in the Boston area, where we can actually speak over Zoom, and maybe they can come in once to get their visit, and then we can continue to work together after that. And that's really important for people that live in areas where there are not a lot of headache specialists around. And so Zoom can be very, very helpful. I often tell patients to keep trying to find a headache medicine specialist that you can really connect with. And it's an important thing. It's not anything personal against a headache medicine provider. If you don't connect with them or you don't make a good relationship with them, it's not about them anyway. It's really about you. So I tell patients, you do need to have a good working relationship with your headache medicine specialist. You need to have some ability to communicate with them and trust them. And they need to be able to do the same and respect you and give you a voice as well. So I encourage patients to keep trying to find a headache medicine specialist that fits into that realm. And now with Zoom, I think it's probably a little bit easier to connect with headache medicine specialists that are not just in your area if there is difficulty.
Yeah, you're right. You're right. That is a positive with the telemedicine features. You might be able to go outside your area to some of you wonderful providers. We got another question about elaborating a bit more about the connection between food and migraine. There's another backup question after that, but can you elaborate what your thoughts are on the connection or non-connection between food and migraine?
Yes. So I think that for some patients, not all, for some patients, there is a connection. So for example, I'll have patients that say that they notice a pattern that if they eat large carbohydrate loads, for example, or a carbohydrate heavy meal, that can precipitate a headache within 24 hours. Or if they eat a specific food, that'll precipitate a headache. Some patients are very sensitive to nitrogen containing foods, or foods that have nitrates, for example. Some patients are exquisitely sensitive to very pungent foods, like certain types of cheeses. Some people think that it's the cheese itself. Sometimes it's just the pungency of the cheese and the actual smell of the cheese. And there are people that are also sensitive to things like certain types of wine, especially red wines and the tannins in them. And some people are sensitive to things like things that contain caffeine. Chocolate contains a little bit of caffeine, and of course, caffeinated products and withdrawal from those. So there can be a connection absolutely between food and what types of food you eat and whether or not that triggers a headache. And yet other people, it's more complex than that. In other words, their eating habits are a reflection of something else. Like they eat more of a certain type of food when they're lacking in sleep, or their diet changes if they're anxious or in a certain type of mood state that can also precipitate a headache, and in that way connect food to headache. What I do find interesting from a neurobiological perspective is that there is a particular area in the brain that sometimes helps to control food cravings. It's called the hypothalamus. That's also an area in the brain that's involved in things like sleep regulation and stress. And we are now understanding that that area in the brain may also be involved in migraine attacks. It's activated right before a migraine attack in migraine patients. And so it could be that some of the food cravings that people have are misconstrued as triggers, in that they tend to crave certain foods, and it's a reflection of the fact that this area of the brain is abnormally signaling. So there's a lot going on around food and understanding these food cravings. But what I will say is that if you do not have a food-related trigger, then you do not necessarily have to be very restrictive in your diet. That's what I tend to say. It's best to eat a well-rounded, well-balanced, healthy, to have a well-rounded, well-balanced, healthy diet than it is to have an extremely restricted one. And so I typically tell my patients, just make sure that they're eating healthy. I think that is more important than being very restrictive for people that don't have any obvious food triggers.
Great. You always like to hear the hopefulness of it. And it's interesting to say that where some people may feel that it's a food trigger, it's actually could be lack of sleep that changes. So it's really the whole body. The whole body needs to be treated. We'll leave, I have one more question, and then I'm going to leave you with one statement. You're so hopeful, and you can tell that you're really passionate about what you do. Would love to end on a comment in that area, because this next one I know though is asked quite often. And what's your advice if you're stuck in a situation with your doctor with a rather, and you're having a confrontation, so to speak? Do you have an idea or a way to sort of help de-escalate when you're in a situation with your doctor, kind of a sticky situation with your doctor?
Yes. So this can happen for a number of different reasons. I often find that one of the best things that you can do is sort of pause and reflect and think about what is it that's causing the sticky situation, and then trying to then say what that is, to communicate what that is. So for example, oftentimes it's things like, I don't feel that I'm being heard, or I don't think that you're allowing me to finish a sentence, or I don't think that you're affirming how I feel, or I don't think that you're really taking seriously what I'm saying, or I feel like I'm being brushed off. And I think that those kinds of statements, if you just say it that way, can help a little bit for the physician to kind of reflect on how they're saying things or the way that they're saying things. And I think that can be very helpful. Sometimes, you can say, I think we should maybe end this meeting and regroup, or, I understand what you're saying, but I don't feel like I'm being heard. Perhaps we can talk about this further. And then sending a message to your doctor, saying, these are my concerns, and I really just don't feel like I'm being heard, can be helpful. It's difficult for doctors too, because they don't want to be in positions where things are escalating either, right? That makes it very difficult for both sides to really be able to communicate. So I think just taking a step back and thinking about, why are things escalating? Is it because I'm in severe pain and I just don't find that anything is working? Is it because I feel like I'm not being heard? Is it because I feel like, my doctor has a million things to do and they just don't have time for me? What is it? and communicating whatever that thing is can help to readdress the relationship.
Great, thank you. You're so peaceful. And I guess that wraps it up. You've just really been invaluable. If there's any last comment you want to share with the group?
My last comment to share is that, you know, the headache medicine physicians community, we're super excited about the new medications that are coming out and all of the advances that have been made because people are doing research, because people really want to find out the underlying cause of migraine and how we can treat it. And so we are hopeful and excited about the future of migraine treatments. And so I hope that gives you guys hope as well that we're working on it.
Thank you. Thank you. It certainly does. I just always love to hear that because it is so encouraging for people in this community. Thank you again for being with us, Dr. Harriott. It was a pleasure having you.
Thank you.
We're fortunate.